Dear students, Assalamu alaikum. Acid-base regulation 3. The objectives of today's lecture are to learn about quantification of acid-base excretion, regulation of hydrogen ion secretion, and renal corrections of acidosis and alkalosis. Quantifying renal acid-base excretion. Bicarbonate ion excretion and regeneration of new bicarbonate ions is calculated by multiplying the urinary concentration of bicarbonate ions and ammonium ions by urine flow rate. The rest of the non-bicarbonate, non-ammonium buffers excreted in the urine is measured by determining a value which is known as titratable acid. The amount of titratable acid in the urine is measured by titrating the urine with a strong base, such as sodium hydroxide, to a pH of 7.4. Remember, the titratable acid measurement does not include hydrogen ion in association with ammonium ions. To maintain acid-base balance, the net acid excretion must equal number 1, non-volatile acid production in the body, and number 2, it must equal the rate of net bicarbonate ion addition to the blood. In acidosis, therefore, there is a net addition of bicarbonate ion back to the blood, as more ammonium ions and urinary titratable acid are excreted. In alkalosis, there is a negative net acid secretion. There is a net loss of bicarbonate ions from the blood, and no new bicarbonate ion is generated by the kidneys, because in alkalosis, titratable acid and ammonium ion excretion drop to 0, whereas bicarbonate ion excretion increases. As we studied earlier, and as I have mentioned repetitively in the previous slides, that hydrogen secretion is necessary for both bicarbonate reabsorption and generation of new bicarbonate ions. Therefore, the rate of hydrogen ion secretion is very carefully regulated, and that is the topic of this section: regulation of renal tubular hydrogen ion secretion. The kidneys tubule must secrete at least enough hydrogen ions to reabsorb almost all the bicarbonate ions that is filtered. There must be enough hydrogen ion left over to be excreted as titratable acid or ammonium ions in order to rid the body of non-volatile acids. In alkalosis, tubular secretion of hydrogen ions is too low to achieve complete bicarbonate reabsorption, enabling the kidneys to increase bicarbonate excretion. In alkalosis, titratable acid and ammonia are not excreted because there is no excess hydrogen ions available to combine with non-bicarbonate buffers. Therefore, no new bicarbonate is added to the blood in alkalosis. In acidosis, tubular hydrogen ion secretion is increased sufficiently to reabsorb all the filtered bicarbonate ions. Enough hydrogen ions are present to excrete large amounts of ammonium and titratable acid. This contributes large amounts of new bicarbonate ions to the total body extracellular fluids. The most important stimuli for increasing hydrogen ion secretion by the tubules in acidosis are: number one, an increase in partial pressure of carbon dioxide in respiratory acidosis, and number two, an increase in hydrogen ion concentration in respiratory or metabolic acidosis. Excessive aldosterone secretion, as in Conn's syndrome, also increases hydrogen ion secretion. This increased secretion of hydrogen ions increases the addition of bicarbonate ions back to the blood. This usually causes alkalosis in these patients. Decreased extracellular fluid volume increases hydrogen ion secretion and bicarbonate reabsorption by number 1 increasing angiotensin 2 levels, and number 2 by increasing aldosterone levels. Therefore, decreased extracellular fluid volume tends to cause alkalosis due to excess hydrogen ion secretion and bicarbonate ion reabsorption. Changes in plasma potassium concentration can also influence hydrogen ion secretion. Hypokalemia stimulating and hyperkalemia inhibiting the hydrogen ion secretion in the proximal tubule. Decreased plasma potassium concentration, that is hypokalemia, increases the hydrogen ion concentration in the renal tubular cells. This stimulates hydrogen ion secretion and bicarbonate reabsorption and leads to alkalosis. On the other hand, increased potassium concentration, that is hyperkalemia, decreases the bicarbonate secretion and decreases the hydrogen ion secretion and bicarbonate ion reabsorption and tends to cause acidosis. Let's now summarize the factors increasing hydrogen ion secretion and bicarbonate ion reabsorption. Increased partial pressure of carbon dioxide, increased hydrogen ion secretion and decreased bicarbonate ion secretion. Decreased extracellular fluid volume, increased angiotensin 2, increased aldosterone and hypokalemia. Factors decreasing hydrogen ion secretion and bicarbonate reabsorption, decreased partial pressure of carbon dioxide, decreased hydrogen ions, increased bicarbonate ions, increased extracellular fluid volume, decreased angiotensin 2, decreased aldosterone and hyperkalemia. Okay, let's now move on to the next topic, in which we will learn how the kidneys readjust the pH of extracellular fluid when pH becomes abnormal. First, we will study renal correction of acidosis. This happens by increased excretion of hydrogen ions and addition of bicarbonate ions to the extracellular fluid. Acidosis occurs when the ratio of bicarbonate ions to carbon dioxide in extracellular fluid decreases, thereby decreasing the pH. If this ratio decreases because of a fall in bicarbonate ions, the acidosis is referred to as the metabolic acidosis. And if the pH falls because of an increase in partial pressure of carbon dioxide, the acidosis is referred to as respiratory acidosis. Now, acidosis decreases the bicarbonate ion hydrogen ion ratio in renal tubular fluids. Respiratory and metabolic acidosis both cause a decrease in the ratio of bicarbonate ions to hydrogen ions in the renal tubular fluid. In metabolic acidosis, an excess of hydrogen ions over bicarbonate ions occurs in the tubular fluid primarily because of decreased filtration of bicarbonate ions. This decreased filtration of bicarbonate ions is caused mainly by a decrease in the extracellular fluid concentration of bicarbonate ions. On the other hand, in respiratory acidosis, the excess hydrogen ions in the tubular fluid is mainly due to the rise in the extracellular fluid partial pressure of carbon dioxide. Therefore, in both types of acidosis, there is excess hydrogen ions in the renal tubules, causing complete reabsorption of bicarbonate ions and leaving additional hydrogen ions available to combine with urinary buffers like ammonium ions and hydrogen phosphate. So, to summarize, in acidosis, the kidneys reabsorb all the filtered bicarbonate ions and the kidneys contribute new bicarbonate ions through the formation of ammonium ions and the titratable acid. In respiratory acidosis, there is a reduction in pH, an increase in ECF hydrogen ion concentration, and an increase in partial pressure of carbon dioxide. The compensatory response in respiratory acidosis is an increase in plasma bicarbonate ions caused by the addition of new bicarbonate ions to the extracellular fluid by the kidneys. Coming to the metabolic acidosis. In metabolic acidosis, there is a decrease in pH and a rise in extracellular fluid hydrogen concentration. And in this case, the primary abnormality is a decrease in plasma bicarbonate ions. The compensatory response in metabolic acidosis is number one, increased ventilation rate, which reduces the partial pressure of carbon dioxide, and number two, renal compensation, which is addition of new bicarbonate ions to the extracellular fluid. Coming to the renal correction of alkalosis. Here, keep in mind that, understandably, the compensatory responses to alkalosis are basically opposite to those that occur in acidosis. Remember, alkalosis increases the bicarbonate hydrogen ratio. In alkalosis, the ratio of bicarbonates to carbon dioxide in the extracellular fluid increases, thereby increasing the pH. Whether the alkalosis is caused by metabolic or respiratory abnormalities, there is an increase in the ratio of bicarbonate ions to hydrogen ions in the renal tubular fluid. The net effect of this is an excess of bicarbonates that cannot be reabsorbed from the tubules and is therefore excreted in the urine. In alkalosis, bicarbonate ion is removed from the extracellular fluid by renal excretion, which has the same effect as adding an hydrogen ion to the extracellular fluid. This process helps return the hydrogen ion concentration and pH towards normal. Now let's study the subtypes of alkalosis. Respiratory alkalosis. In respiratory alkalosis, there is an increase in extracellular fluid pH and a decrease in hydrogen ion concentration. The cause of the alkalosis is decreased plasma partial pressure of carbon dioxide caused by hyperventilation. Reduction in partial pressure of carbon dioxide leads to decreased renal tubular hydrogen ion secretion, as we noted earlier. Now, there is not enough hydrogen ions in the renal tubules to react with the filtered bicarbonate ions. Therefore, the bicarbonate ion that cannot react with the hydrogen ion is not reabsorbed and is excreted in the urine, resulting in decreased plasma bicarbonate ions and leading to the correction of the alkalosis. Therefore, the compensatory response to a primary reduction in partial pressure of carbon dioxide is a reduction in plasma bicarbonate concentration caused by increased renal excretion of bicarbonate ions. In metabolic alkalosis, there is also decreased plasma hydrogen ion concentration and increased pH. The cause of metabolic alkalosis, however, is a rise in the extracellular fluid bicarbonate concentration. This rise is partly compensated by a reduction in the respiration rate, which increases partial pressure of carbon dioxide and helps return the extracellular fluid pH toward normal. In addition, increased bicarbonate ion in the extracellular fluid increases the filtered load of bicarbonate ions, which causes excess bicarbonate ions over hydrogen ions secreted in the renal tubular fluid. The excess bicarbonate ions in the tubular fluid fails to be reabsorbed because there is no hydrogen ions to react with, and it is therefore excreted in the urine. Therefore, the compensatory response in metabolic alkalosis include: number one, decreased ventilation, which raises the partial pressure of carbon dioxide, and number two, increased renal bicarbonate ion excretion. And this helps compensate for the initial rise in the extracellular fluid bicarbonate ion concentration. I stop here to end today's lecture.